So last time we were looking at disorders of the cardiovascular system, specifically hypertension. Now let's look into hypotension. At least here, what we have in this information, it tells that hypotension is having an abnormally low blood pressure that can either be chronic, but most cases will be acute. And then this is defined as having a low pressure below 90 for systolic and below 60 for diastolic. And we are talking about an adult. Some athletes, young people, thin people, have normally these readings or below. So I'm going to be a little bit contradictory here to this information because what definitely defines then blood pressure low for those who typically have it like that, it is not only having a low reading of blood pressure, but also having dizziness and fainting. I'm sure that among some of you, I can start taking some blood pressure there, and I will see you even have some lower than that, and you're perfectly healthy. You don't feel dizzy or things like that. Now, for sure, when you have mild hypertension, you can feel dizzy and also faint. But when you have severe hypertension, you can fall into what is called cardiovascular shock or circulatory shock. In this case, you have severe loss of volume in your bloodstream and low blood pressure because of that. Typically happens when someone has a hemorrhage, massive hemorrhage, and then the person don't have as much volume, so the heart cannot pump what it doesn't have. So there is no compensatory mechanism initially unless the person receives proper medical treatment, which basically will be providing a liquid that increases blood volume. So that it is the severe hypertension then happening because someone has hypovolemia, which is reduced blood volume. Now, sometimes, yes, you can have normal volume, and then you can have still cardiovascular shock, but that's when you have a problem in your body, like, for instance, if someone has a severe allergic reaction, and then you will have opening of or widening of your blood vessels and consequently loss of this volume into the interstitial fluid. And then the heart also can be not pumping as efficient. So yes, those are cases. But what else can cause hypovolemia or low blood volume? Well, not only a hemorrhage, but also severe diarrhea, vomiting, overuse of diuretics, or insufficient intake of fluids. All of those are causes of hypovolemia. And then if this blood volume is not restored, then the person can have what is called hypovolemic shock, which leads to circulatory shock. Some people may have medications that reduce the cardiac output, like some blockers of calcium channels. Others will be, for instance, severe heart failure into what we call cardiogenic shock. If the heart is not pumping efficiently, of course, that reduces the amount of blood that is pumped per minute, which is the cardiac output. Other causes will be vasodilation. So, for instance, some medications like antihypertensives can cause vasodilation. Medications for treating acidosis, or maybe the person has a problem with the sympathetic system, ANS dysfunction. Histamine released into the bloodstream due to a severe allergy. Open up the walls of the blood vessels. You have leakage of fluid outside the blood vessels into the interstitial fluid. So this is what we call anaphylactic shock. So basically everything is shock, but you call it differently. Cardiovascular shock is a generic name that includes cardiogenic shock when the pump fails, when the heart fails. If it's lack of blood volume, will be hypovolemic shock. And then anaphylactic shock, if you have a severe allergic reaction, or if you have a bacterial infection in the blood, it's called septic shock. And all of these can lead to cardiovascular shock. So for mild hypertension, you can increase fluid intake or change the medications if that's what is causing the hypertension. Severe hypertension requires to be treated in the hospital because a person can die. And you can give fluids, IV fluids, to increase blood volume or blood in the case of someone who receives blood transfusions. But also you can give drugs that increases the cardiac output. Who has seen what persons who have had a severe allergic reaction before carry to prevent that severe allergic reaction to happen again? An EpiPen. So that one has epinephrine. That causes vasoconstriction. So that raises cardiac output because your heart pumps harder, stronger and more times, and also vasoconstricts. Now for capillaries, now we're going to talk about the function of capillaries. So capillaries allow a specific amount of blood to go into the organs. So this is known as tissue perfusion. And then most of our tissues of our body, of course, have capillaries, with few exceptions like epithelial cells, cartilage, which is a vascular similar as the epithelial cells, and tissues in the eye like the sclera and the cornea, which is an epithelium. The thickness of the walls of the epithelium of the capillary is 0.2 micrometers. It's very thin. This allows rapid diffusion of oxygen, nutrients, and fluid itself. And the length varies, but the average is 50 micrometers in length, and the diameter is between 8 to 10 micrometers. Sometimes it can be even smaller than that. So typically the cell wall of the wall of the capillary is made out of 3 cells that wrap around each other a little bit. They form the circumference. And then you can have small contractile cells around this endothelium or tunica intima of the capillaries, which are called the pericytes, or side cells around, peri for around. This one, it seems like, will be kind of an sphincter that controls tissue perfusion. So here is the structure of the capillaries. So it's made out of 3 endothelial cells, almost overlapping in some regions. No muscle cells, but you can have these pericytes. And then this is a light microscopy view of a capillary with blood cells inside, red blood cells. This formation look like stacks of red blood cells is called ROLU. like Rolex, like the watch. It's very expensive, but it's with uh, a U and an A. Rolex. So what happens, or what is the function of the capillaries? It's exchange. You exchange nutrients, gases, oxygen, carbon dioxide, hormones, whatever your cells need. And then the exchange happens through three mechanisms: diffusion and osmosis through gaps and fenestrations. Fenestrations are large in fenestrated capillaries, like you can move small solutes like sodium, potassium, chloride, ions. You can move as well amino acids. We have fenestrated capillaries in the spleen, in the bone marrow. And then we have another mechanism, diffusion through the membranes in continuous capillaries, like oxygen, carbon dioxide, molecules that are hydrophobic. They can move through these capillaries really easily. The third type of movement in these capillaries is called transcytosis. In this case, you have larger substances that lives into the cell by endocytosis and then exits in the other side through exocytosis. Transcytosis. So here is a view of the capillary exchange mechanisms. So here you have these little gaps that allows the diffusion of and osmosis through these gaps and fenestrations. And in this case, we have simple diffusion, like oxygen, CO2 can move, or you can have transcytosis. So molecules can enter through endocytosis and then leave through exocytosis. And here are fenestrae, which are large gaps. So according to certain characteristics of the cells, the capillaries can be classified as continuous if the cells are close to each other. And we have it everywhere in our body, including muscle, skin, nervous, and connective tissues. They have the least leaky with tight junctions in between. So substances here move through diffusion, of course, like in any other capillary type, but also through transcytosis. So in our brain and in our, we have modified continuous capillaries. So they have a lot of tight junctions. So they form, if you remember from AMP1, they have the blood-brain barrier, or triple B, BBB. Why? Because this tissue is very delicate, very fragile, that not all the substances can cross easily. So that's why you have to have strong connections between the cells. You have to have tight junctions. Other places in the body, well, will be in males in the testicles. They have the blood testis barrier to prevent the immune system to destroy the sperm cells. And then fenestrated capillaries. They are located in endocrine glands, in the small intestine, and the kidneys. They are more leakier than the continuous capillaries. So they have pores that allow a faster diffusion of larger molecules than in continuous, like the hormones from the endocrine glands. Sinusoids or sinusoidal capillaries, they definitely have very big space, so they are discontinuous, and they have an irregular basal lamina. So these will allow the movement of proteins, like in the case of the liver proteins, in the spleen, we have them as well. We have it in lymphoid organs and in the bone marrow. So the cells of the blood, like the white blood cells, red blood cells, passes through these sinusoids in the bone marrow. So they have the greatest degree of transport in a way. So here is the different type of capillaries. This is continuous, very close cells, fenestrated. You see these gaps that are called fenestra. And then here we have the large gaps that we call sinusoids. So these are sinusoidal capillaries. Again, we have it in places that allows the exit of proteins like the spleen, the liver, the bone marrow, including large molecules, cells like the red blood cells, white blood cells. And here is a table showing you where they are located. We already went through this. So we have in the capillary beds in our tissues something that is called the microcirculation. The microcirculation includes the true capillaries where materials are exchanged, and then you have a central vessel that basically acts like a little funnel that leads to a meta-arteriole. And you have transfer of this blood from the thoroughfare channel of the central vessel into the venules, so that you can have blood going from the arteriole to the venule. And then each of these capillaries, especially at the beginning of this capillary bed, will have a precapillary sphincter, which is nothing else but a circular layer of smooth muscle cells that can close and open to allow the basically movement of blood. The movement of blood into these capillary beds will be proportional not only to the tissue type, but also to the activity of this tissue. Our brain, per gram, it receives more blood than any other organ in the body. And it makes sense because that's where we have the most active cells, which are the neurons. It controls a lot of functions, so they have to have a lot of oxygen, a lot of nutrients. And that's at the basal level. Like someone maybe be in a coma and still the brain will receive a lot of blood perfusion, tissue perfusion. But then think about someone then who's studying for a final, or someone who's very studious, is constantly studying. Don't you think that the person is going to have more perfusion? Of course it does. So then that perfusion can be controlled with these precapillary sphincters. So here's the microcirculation. So you have an arteriole, which is the smallest of the arteries that we have, and then here we have a venule, which is the smallest vein. And in between, we have the capillary beds. The capillaries are connecting both venules and the arterioles. And then if you notice, we have here this thorough channel, which is basically part of this meta-arteriole. The meta-arteriole carries oxygenated blood, and the thorough channel basically carries the oxygenated blood, as you can see by the switch of color from red to blue. And these meta-arterioles basically delivers blood into these capillaries on the sides, and you have these precapillary sphincters that can control how much blood goes into these capillaries. So it's like a city with the streets. It might have a main street, and then it has secondary streets. So let's say that you want to control the traffic in that street. Well, you close these small streets on the sides, and you only have people driving into the main street. So similarly, we have these precapillaries closing and allowing possibly blood from going directly from arterioles into venules in some occasions. So why will someone or why in some events you want to have blood going directly from arterioles to venules and not passing into these capillaries? Why? Why you are restricting blood into these and you're passing blood only from the artery into the vein? You close your capillaries here, and then you're transferring the blood from artery to vein. Why? 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 Huh? What happened to me? Or wow. Huh? Hemorrhage. In a hemorrhage. Oh. You want to shut down your capillaries from organs that they don't need the blood supply right now. And you open up the capillaries of what tissues in a hemorrhage, in an emergency situation. Where do you want to send the blood? You want to send it right away to the heart. And then from the heart goes into the brain, the most important tissue in our body. So basically you're shunting the fluid. So you don't want to have this cardiovascular shock, this hypovolemic shock. So see, then in here, this is what normally happens. You have this normal blood delivery, but if you just shut down these capillaries, do you see any blood here? No. But the blood goes directly now into these venules. And then from there it goes into the heart, and the heart has something to pump. Now, not necessarily can happen that way. I mean, sometimes we reduce blood supply to organs that are not more active. Like if you eat, of course you are going to open your capillaries to absorb as much nutrients, but once you absorb the nutrients, you shut them down, and then you open the ones more from your brain so that you receive the glucose from the nutrients that you just ingested. So then that process of closing and opening the capillaries with these precapillary sphincters is known as myogenic mechanism. So this is autoregulation or local regulation of tissue perfusion. Another example, for instance, when someone starts doing exercise, it starts releasing CO2, and that CO2 helps to open more the capillaries of the muscles so that you release more oxygen. because you are doing exercise, your muscles require more oxygen to use ATP and to generate ATP. So another thing that controls the perfusion is metabolic controls. And that's what I told you about the use of oxygen and ATP. So these are chemicals that can regulate the tissue perfusion. Nitrous oxide is a vasodilator that allows more blood perfusion to go into particular tissues. In the special circuits, we receive particular amount of blood. So for instance, the heart, which is basically less than 0.5% of our body mass, receives 5% of the total cardiac output per minute. Something about the heart, it is that it receives blood supply during diastole rather than systole. And this is because during systole, as it's contracting, it's going to compress the coronary arteries. And compressed coronary arteries cannot deliver the blood. So the muscle of the heart has to relax in diastole to receive the blood supply, while in the rest of the body, we receive the blood supply during systole more than during diastole. So in resting conditions, then the heart has a flow of 60 to 70 milliliters per minute per 100 grams of tissue. And look how much increases when we do exercise, 250 milliliters per minute. So basically, if this is the maximum, it's almost 4 times when we exercise. Like 70 times 4 is 280. And this is 250 milliliters. So it's almost 4 times the amount of blood that we receive in the heart every time that we do strenuous exercise. So this is one of these exercises that you will be doing in the cardiovascular physiology lab. Like do a little bit of exercise to increase your blood supply. The brain makes 2% of our body mass and it receives 15% of the total cardiac output. So we have 750 milliliters per minute of constant cerebral blood flow. Without thinking that sometimes we are more active with our mental processes. And then certain areas of the brain receives more blood supply because you have more activity, and that basically it's correlated to releasing more vasodilators. Skeletal muscle basically has a blood flow that can increase as much as 50% fold during exercise. This is known as hyperemia. It's the opposite of anemia. We have in our skeletal muscle specific arteries that are called nutrient arteries or feed arteries, and then they end up in the terminal arterioles. And these feed arteries basically are having certain resistance that is high, and then many terminal arterioles will be constricted, especially during contraction. So when we do exercise, we release molecules that are byproducts of glycolysis that open up these blood vessels, and that dilates, of course, the feed arteries so we can receive more blood supply. So here is then what happens. So We have this feed artery that dilates in response of whatever exercise we're doing. And then as this one dilates, of course, we have the arterioles that contact all of these muscle cells directly within the muscle, and then they dilate together with these terminal arterioles in response to the vasodilators that are released during exercise, because we have these byproducts of glycogen and, glucose metabolism, not glycogen. Now, in our skin, we have this set of capillaries in the dermis that can vasoconstrict and vasodilate in response to body temperature. If your body temperature is high, your blood vessels will be vasodilated, so you can dissipate the heat. So you have more blood passing through these blood vessels. And then when it's cold, if your body temperature is cold, you have vasoconstriction, at least in the surface, in the skin, blood vessels, so that you will retain the core heat, the core temperature. That's where it's more important. And just as a reminder, the nerves that innervate your blood vessels, the middle layer, the tunica media, is sympathetic nerves, not the parasympathetic. So depending on how active is the sympathetic is whether you have vasodilation and vasoconstriction. If it's less active, you have vasodilation. If it's more active, you have vasoconstriction. Now for the physiology of the capillaries. So basically, you have the mechanism of filtration that happens as a result of having physical forces that either maintain the fluid inside the capillaries or makes this fluid to exit the capillaries or enter into the capillaries in some cases, depending on what type of capillary it is, and also depending on which end of the capillary you are considering. The physical forces are hydrostatic pressure, or HP, and osmotic pressure, or OP, which also is known as oncotic. So hydrostatic pressure is opposite to the osmotic pressure. Hydrostatic pressure pushes the fluid out of the capillaries, while oncotic absorbs liquid into the capillaries, draws liquids into the capillaries. So they made this figure that it shows that you have water in a beaker, and that water exerts pressure against the walls of the beaker. And if you have openings in this beaker, of course the water will exit from higher hydrostatic pressure to lower hydrostatic pressure. So just as everything in physiology for this diffusion or these pressure gradients from more to less. And then in osmosis, if you remember, you have movement of water molecules across a semi-permeable membrane from an area of low concentration of solids to high concentration of solutes, or from an area of high concentration of water to low concentration of water. So that one is going to play a role when it comes to the capillaries, because as the blood is moving to these capillaries and you're losing fluid, you will increase the concentration of solutes in the terminal end of these capillaries, which is the venous end. And that will make the capillaries to have a side that absorbs rather than a side that secretes. So osmotic pressure will be the force that must be applied to a solution to prevent water to move. And that will happen actually in the middle, or not the physical middle of the capillary, but in the transition between the arterial end and the venous end. Now, that oncotic pressure or osmotic pressure, it is influenced by proteins in our blood, but specifically by albumin, which is a large negatively charged molecule. Some people may have damage to their kidneys, and they will losing a lot of proteins, including albumin. In this case, their osmotic pressure is very low, that they tend to lose fluid, so the fluid goes from their capillaries into the interstitial space, and then the person will be edematous, so they will be puffy. So here we have these pressures. Now, we can have osmotic pressure in the capillaries, but also we can have it in the interstitial fluid, and they are opposite. And then we have a total pressure that is called colloid osmotic pressure, that basically it is subtracting the interstitial pressure from the capillary pressure. The interstitial pressure is less than the capillary pressure. So the capillary oncotic pressure is 25 millimeters of mercury per minute that we use to measure the pressure, and the interstitial is 3. So 25 minus 3, that gives you a total colloid osmotic pressure of 22. So this is what actually happens in these capillaries. So this is for hydrostatic pressure, this is for osmotic pressure. This is the arterial, this is the venial, arterial venial, and this is a capillary. The part of the capillary that is close to the arterial will be the arterial end, and the part of the capillary that is close to the venial will be the venous end. In this end, in the arterial end, you have a hydrostatic pressure of 35. So this will be the force that makes water, see this part, water moving out. So as you're losing water and the blood goes from arterioles to venules, you start losing hydrostatic pressure. So because you lose hydrostatic pressure, then you don't have more exiting of water. And then here we have an area where you have a transition. So here you had initially a hydrostatic pressure of 35, and now you have 50. Now, for the osmotic pressure, if you combine it with the hydrostatic pressure, which is in here, basically it will be going from 25 of this pressure in here, where you have a lot of solutes, proteins, specifically in this case, they're pointing to albumin. So albumin here, where you have water in this arterial end more than here, the oncotic pressure is going to be low. So you don't absorb as much water because this water is basically diluting, in a way, diluting these proteins. But as you lose water, these proteins will become more concentrated, and that will pull water. Now you see how water is moving in because you have concentrated. So while this area is where you secrete water because you have higher hydrostatic pressure in here, this is where you absorb water because you have less water. And everything is just a matter of combining these two pressures, like 35 of hydrostatic pressure, and then you have minus 20, you subtract from this 35, 25 of oncotic pressure, and that leaves you 10 millimeters of mercury of net capillary pressure in this end. And then you have a transition where you don't have either more or less hydrostatic pressure than oncotic pressure, so you don't have any gain or loss of water. But in this end, where you have the venous end, you have less hydrostatic pressure than oncotic pressure. So 15 minus 25. So in this case, that leads to greater osmotic pressure that pulls water into the capillaries, back into the capillaries. So 35 hydrostatic pressure driving water out minus 22 colloid osmotic pressure driving water in. You have a total of 13 millimeters of mercury overall force driving water out. This is called net filtration pressure. And this happens again only in the arterial end, because in the venous end, everything is inverted. You absorb water. So 15 in the venous end of hydrostatic pressure minus 22 of colloid pressure, that leads to minus 7. That's net filtration pressure drawing water in. Now our cells receive more in general than what they can use. Our body is very generous. So you end up with an overall net filtration of 6 millimeters of mercury. If you take into account the net filtration pressure in the arteriole of 13 minus 7 from the venous end, so that leaves you 6 total. And that's what makes our cells to be moisturized. And then what do we do with this excess of fluid? We pick it up with the next system that we're going to consider, which is the lymphatic system. And when someone has an obstruction of their lymphatic system for whatever reason, then that fluid stays there, and this is known as pitting edema. So because of this, then we end up with 2 to 4 liters of water lost from the blood into the interstitial fluid each day. But we pick it up with the lymphatic system that brings it back into the circulation. So everything is just adding, subtracting, and then you end up with a total net filtration pressure of 7. That leaves all of these cells around happy with fluid. And then the rest will be picked up by these lymphatic capillaries. And I guess this is kind of a nice illustration of your book, showing you how if you open completely a faucet and then you have a sponge, the sponge can absorb up to a certain amount, and then the rest will go into the drain. Hopefully you have that in a sink, goes into the drain, which will be kind of the lymphatic system. So edema, it is defined as a condition characterized by excessive amount of water in the interstitial fluid. If someone is standing, you expect that edema will go into the feet and the legs. By gravity, of course, fluid will go into the lower limbs. Now, sometimes some people can have problems in the liver due to diseases like cancer, viral infection, or chronic alcohol use. And then since the liver makes most of the plasma proteins, including albumin, if someone has damage in their liver, they don't have as much albumin in their blood, the person will end up with a fluid that is located in the peritoneal cavity that is called ascites. And the person will have an abnormal belly. Sometimes people can have protein malnutrition, And then they will develop also ascites or fluid in the abdomen. And this protein malnutrition is called kwashiorkor. Lastly, let's review the anatomy of the arteries in the vein with better detail than the first two figures that we saw at the beginning, which were not as good. So, arteries of the brain, anterior view. So we have two major providers for these arteries. We have the internal carotid that passes through the carotid canal in the temporal bone that gives the middle cerebral artery. And out of this middle cerebral artery, you have another branch that is going to be the anterior cerebral artery. So if you see them, you will see them here as part of this polygon of Willis at the base of the brain, around the pituitary gland. So this is the middle cerebral artery, and then this will be the anterior cerebral artery that are joined by the anterior communicating artery. And then the posterior part of our brain will be this part, the occipital lobes, receiving blood supply through these posterior cerebral arteries that are branches of the basilar, and that they join the middle cerebral artery through this posterior communicating. Where does this basilar artery, which is this, comes from? It comes from the anastomosis or joining of the left and right vertebral arteries that passes through the vertebral tell me the name of this foramina, guys, in the cervical vertebrae. Transverse foramina. It's in the transverse processes. So the right and the left vertebral arteries merge here at the level of the pons, forms this basilar artery, and then this one is going to bifurcate or split into the left and right posterior. And all of this provides this circle of Willis or polygon of Willis or arterial circle. So here we have anterior communicating, arterial cerebral, middle cerebral, posterior communicating, posterior cerebral. Why do you think we have this roundabout of blood vessels around the base of our brain? Why do we have that? Why don't we have just a single blood vessel to give blood supply to the entire brain?
It doesn't need a bunch of blood.
Hmm?
The brain need a lot of blood. The blood length.
Well, but you can have a large blood vessel that provides a lot of blood, but why we have it instead of just a large single blood vessel? Why we have many tiny branches and they are interconnected in a roundabout? Let's say that someone has a stroke in the left posterior cerebral artery. A stroke that basically obstructs the blood supply to this artery. So what is the purpose then of having this if you have an embolus, blood clot that obstructs this artery? It allows continuous blood flow still. Within its limitations. Don't think that it's perfect. Otherwise, people who will have strokes, we will recover completely. But it's kind of redundancy. Now, arteries of the thorax. And just like as any other artery in our body, all the arteries derive from the aorta. So aorta has three segments. The one that goes up, that is ascending, the next one that is the arch, and the one that goes down, that is descending. Descending is subdivided into thoracic above the diaphragm and abdominal below the diaphragm. In the thoracic area, we have lateral branches that are called the bronchioles, and posterior intercostals. Bronchioles follows the bronchi in our lungs to provide blood supply to the tissues in the lungs, and the intercostals, the posterior, they run in the lower edge of the ribs, protected by the vein that it's more external, the intercostal veins. And these posterior intercostals join the anterior intercostals, which are branches of the internal thoracic artery that runs here almost to the sides of the sternum. And then we have here in this diaphragm the superior phrenic artery. And then we have some branches that are not shown here, like the pericardial arteries. And then we have esophageal that provides blood supply to the esophagus, which brings the food from the mouth into the stomach. And then these internal thoracic is branch of these arteries here that are located, the ones that I'm pointing here. So this is the internal thoracic, right? That goes down here on the sides of the sternum. But these are branches of these ones. What is the name of these arteries here? Subclavian. I wanted to make sure that you remember those names. Arteries in the abdomen. So we have 3 anterior branches: celiac trunk, superior mesenteric, inferior mesenteric. Lateral branches, we have the middle suprarenal, we have the renal, we have gonadals, testicular or ovarian, and then we have the lumbars. And then for the celiac trunk, this is the magnification. So we have the hepatic proper, we have the left gastric, and then we have this splenic. And then we have the left gastric that runs here and the right gastric that runs here. Superior mesenteric, it distributed to the intestines inside this membrane that's called the mesentery, and also to the first 2/3 of the large intestine by the ileocolic, right celiac artery, and the middle colic artery. Sorry, not celiac, right colic artery, and then the middle colic artery. So these are called intestinal arteries. And then for the inferior mesenteric, it gives you the inferior colic artery, which is this, the sigmoidal arteries, and then the superior rectal. Any questions about this? Arteries of the upper limb, they are branch of the subclavian. Subclavian are branches of the brachiocephalic. So subclavian, once it reaches the armpit, it's going to change its name into the axillary. And then while it's running in this area, it's going to provide blood supply to muscles in the shoulder and also to the joint shoulder by this circumflex, which is posterior and anterior. And then this axillary, once it's near to the humerus, is going to be brachial. And then the brachial bifurcates at the level of the elbow joint, and it gives also some branches to the elbow joint, but it bifurcates into this lateral artery, which is the radial, and into this medial, which is the ulnar. And then both of them, they form the deep and superficial palmar arches. And out of these palmar arches, we have these ones that are not labeling here, that are the metacarpals, and then the ones that runs on the sides of the fingers that properly will be called digital. And then we have digital veins as well. And then we have nerves as well here on the sides of our fingers. So, why in the world we have these arteries, veins, and nerves here, but not in here? Not anteriorly, not posteriorly, but rather we have it here on the sides. Is it a mistake of the designer put them in here rather than in here? Or why it's there? For what? Starts with a P, ends with an N.
Protection.
For protection. Imagine if you were carrying a bucket with water or joint cement. Go to these stores and you buy a heavy bucket and you're carrying it like that. What will happen to your blood supply to your fingers if you have the blood vessels in here, guys? It will cut off. Every time that you squeeze something, you have bluish fingers. And also the nerves the same. We have them here on the sides. When they're going to anesthetize the fingers, they do it in here. It's for protection. Arteries of the lower limb, they are derivatives, of course, from the iliac, the external iliac. Now, the abdominal aorta bifurcates or splits into the two common iliacs, the right and the left, and they're located here. That's why they're called iliacs, in the iliac region. Now, the iliac, the common, splits into the internal, which goes posteriorly, and then into the external that goes anteriorly, continues down, and after this ligament that is called the inguinal ligament, it will be called the femoral. And then we have two types of femoral. We have the femoral, just plainly femoral, and then we have the deep femoral, which is this one that runs posteriorly. Now, this femoral, once it's at the level of the back of the knee, is going to change its name into popliteal. And then this popliteal is going to split into one that goes anterior to the tibia and another one that goes into posteriorly into the shaft of the tibia. So will be anterior and posterior tibial artery. And then out of this anterior tibial and the posterior tibial, you will form the arches and the plantar arches, and also the dorsalis pedis, which is just like the radial artery, it's another major pulse point. And then we have, of course, the metatarsal arteries, and then the digitals. That just as the digitals that we have in our fingers, they run on the sides of the digits or the fingers. Now, when it comes to the venous drain of the head, it happens through these sinuses that are called dural sinuses. We have the superior sinus, the inferior one, then we have the rectus sinus, the sigmoid, and everything drains into the internal jugular vein. That together with these vertebral veins and the external jugular, they drain into the subclavian to form, together with the axillary, the subclavian and the jugular, they form the brachiocephalic. And the right and the left brachiocephalic will form the superior vena cava that drains into the right atrium. And then we have here the names of these sinuses, including the cavernous sinus, straight, sigmoid, and then superior and inferior sagittal sinuses, and then transverse sinus here. And everything drains into the internal jugular. Internal jugular here merges with the subclavian to form brachiocephalic, right and left, that merges to form the superior vena cava, And everything above the diaphragm is drained by the superior vena cava, including the intercostals, the hemiazygous, the azygous veins, and esophageal. Anything in the thorax drains into that. For the abdomen, we have the inferior vena cava that drains the splenic, the hepatic portal vein, the renal veins, the middle suprarenal, gonadals, everything that is abdominal drains into the inferior vena cava, which is formed by the merging of right and left common iliacs, which forms by the merging of the internal and external. Internal drains pelvic area, external drains the blood from our lower limbs. And here is the distribution of the hepatic portal, which is formed by the merging of these splenic, the superior and inferior mesenterics. They carry nutrient-rich blood that is going to go into the liver to be basically metabolized, and then you drain into inferior vena cava. Upper limb drains the blood from the fingers, the digital, into these palmar venous arches. Palmar venous arches, typically, they are different in each of us. And sometimes we can have genetics to have similar pattern of veins as your family members. Like my grandma used to have, I saw it in a picture. She has veins similar to what my mom had, and basically I have both the veins and even the shape of the hands of my mom and my grandma. So sometimes it's genetics. Now these palmar venous arches then drains into, of course, this ulnar, radial, the median antecubital, and then the median cubital vein into the basilic, cephalic, crazy names to be here in the arm. Cephalic definitely means head, but I told you that it was kind of a spelling mistake there. And then both of them, they drain into the axillary, and then axillary into subclavian, subclavian into the brachiocephalic. Similarly, digitals in the toes drains into the plantar arches, which drains into the anterior posterior tibial, and also drains into the largest vein in our body, which is the greater saphenous. It's here, goes from the ankle into the medial area in our groin. And then the smaller saphenous just runs here from the knee up to the ankle. And then this, together with the femoral, drain into the external iliac, which drains together with the internal iliac into the common iliac. And when both right and left iliac merges, they form which one? IVC, inferior vena cava, that drains into the right atrium together with the superior vena cava. So that's all for this chapter.